Good afternoon, everyone. So we have already had a talk on ARDS management. So we've already seen ventilatory management. So now let us see uh, the other part of the management, that is non-ventilatory management. Before that, we'll just have a small discussion on evolution of the definition of ARDS. So how it started, and then a small talk on baby lung, and then the non-ventilatory strategies. So this is the overview. So, I mean, we already know what is ARDS. So it's a life-threatening respiratory condition characterized by hypoxemia and stiff lungs. The important thing is the mortality is around 30 to 75%. It's always not due to hypoxemia. The problem here is due to non-lung organ failure. So this is the high risk of mortality which we see. So coming to the evolution of the definition, so it all started in 1967. So this was the first definition of ARDS. It was by Asbog et al. So it was mainly based on a case report, based on 12 cases, both adult and pediatrics, who came with acute hypoxemia, non-cardiogenic pulmonary edema, reduced lung compliance, and increased work of breathing, and following a precipitating event. So this is when they started labeling these set of patients as ARDS. Next came a proper definition following a consensus conference between the American and European societies. And this was done in 92, and after consensus from the societies, it was finally drafted in 1994. So according to new definition, ARDS had to be distinguished from other causes of respiratory failure, either due to overload or cardiac causes were to be excluded before saying that to be the respiratory cause of hypoxemia. And after that, this was followed for a pretty long time till recently when the new definition came. So this definition also had some limitations, like there was arbitrary classification as ALI, acute lung injury, and ARDS. So it was just based on the PF ratio. If the PF ratio was 200 to 300, they labeled it as acute lung injury, and if it was less than 200, they called it as ARDS. No logic in that. And apart from that, the other pitfall of this definition was that they recommended the need for a pulmonary catheter to measure the pulmonary wedge pressure if it was less than 18. That is, mainly you're trying to rule out left heart failure as a cause of respiratory distress. And this is also another limitation because we have been rarely using these pulmonary catheters now. And finally came the 2012 Berlin definition, which was validated over a large number of cases, around 4,000 cases, and they made some significant changes. So what was added was hypoxemia is defined after adding a PEEP. So they recommended to add a PEEP of at least 5 centimeters of water and then classify them into mild, moderate, and severe ARDS. The term acute lung injury was removed from the definition. And there was a time lapse, so there was no specific time frame, and they fixed the time frame of around 7 days from the onset of the insult to respiratory distress. And radiologic evidence was further defined. So that is what was the changes which were made. So this is the Berlin definition. So the timing is approximately up to 1 week of a known insult or new or worsening respiratory distress. Origin, respiratory failure, and which cannot be fully explained by cardiac or fluid overload. Imaging showed bilateral opacities on a chest radiograph, which were not completely explained by effusion, collapse, or nodules. And based on the oxygenation with a PEEP of more than or equal to 5 centimeter water, they classify them into mild, moderate, and severe. The PF ratio 200 to 300, 100 to 200, and less than 100 as severe ARDS. So this is a comparison of all three, the Osborg et al. In 1967, AECC definition 1994, and Berlin definition. So you can see the difference. It is already explained, so I'll just skip this slide. And there's one more modification which was made mainly for the resource-limited countries. This is from Rwanda, so this is called as Kigali modification. So in those setups where you can't do a blood gas analysis to get your PaO2, so because we said we're classifying ARDS into mild, moderate, and severe based on the PF ratio, so PaO2 is necessary. Whereas in resource-limited settings where you can't do a blood gas, you can't get a PaO2, so they devised this modification. They said you can even use the SpO2 FaO2 ratio, and if it is less than 315, you can call it as ARDS. Okay, don't need to do a PF ratio. So this is about the definition, how it evolved from 1967 till recent definitions, and you'll see further evolution in this definition as well. A small discussion on the baby lung concept. You already are familiar with. My previous speaker has already told about it. I thought I'll just make a small mention of it. So this is what is the baby lung. So what it really means is that part of the lung which is actually taking part in the gas exchange and which has normal mechanics, near normal mechanics. And it's called baby lung because this size of the lung is just like the size of a lung in a kid who is 5 to 6 years old. That's why it's called baby lung. And it's not an anatomical definition. So it's a functional. So the baby lung can increase. Say if there is increase in pulmonary edema, the baby lung can come down in its size, and you do some recruitment maneuver, or you do a prone ventilation, or add some PEEP, so that man increase the size of your baby lung. So that's all about it. So now going to the evidence-based ventilatory strategies, because we are all familiar with the, non-ventilatory strategies. We are all very familiar with the ventilatory strategies, and we have been doing it better. We have already seen a good lecture on this topic. So now let us look into what are all the evidence which we have and what are the methods which have been available for the non-ventilatory strategies. So these are all the options available: prone ventilation, ECMO, fluid management, neuromuscular blockers, steroids, vasodilators, beta agonists, nutrition. These are only a few to mention, because there are a big list of other drugs which have already been tried in managing or pharmacological managing ARDS. So let us see what is the evidence, what is the practice which we usually follow. A little about prone ventilation. We have already had a small talk in the previous session. So we all know what is one of the ways of treating refractory hypoxemia, and it is also a recruitment maneuver. So because we saw how to do a recruitment maneuver, this is again a recruitment maneuver, and I told you when you do a recruitment maneuver, it will increase the size of your baby lung. So that is what we want in any patient with ARDS management. You want a bigger baby lung so that the gas exchange is better, oxygenation becomes better. So what happens when the person is supine with ARDS because of the pulmonary edema and weight of the heart and the mediastinum, the lungs in the dorsum is compressed, and that is not taking part in the gas exchange. But perfusion is happening very good in the dorsal part, so there is a VQ mismatch, and this is the major reason for your hypoxemia. So when we put the patient prone, so this is what happens. So you can see in the normal, when the ARDS patient is supine, you can see that the dorsal part has large number of alveoli, but it is completely flooded and not taking part in the gas exchange. But you can see that the perfusion is predominantly to the dorsal part of the body. So when you put the patient prone, there is equal ventilation, the edema fluid shifts, and there is better expansion of the dorsal lung region, and we have already seen in the previous slide also, the perfusion almost remains the same, where it is predominantly dorsal oriented. So now the VQ becomes better. So ventilation becomes better because of prone positioning, and the perfusion is already good in the dorsal region, so we have a better VQ, and because of which there is improvement in oxygenation. Apart from the other benefits which you can see, so other one is there is better lung recruitment, bronchial drainage is also better. You're putting the patient down, the endotracheal tube is in the gravity dependent position, so it will help in facilitation of the drainage of the secretions. Apart from that, I've already told you there's better VQ match and things like that. So this is how the physiology, how prone ventilation helps in improving oxygenation or improving the lung mechanics. So what is the evidence for this? So the famous study which all of us know is ProSEVA study. It included 466 patients, PF ratio less than 150 were considered for this, because in the previous studies they have already seen that all the cases with ARDS, like mild, moderate, severe, everybody were considered for prone ventilation, but they found that the results were not that great because everybody was included. So in this, they took only severe cases to moderate cases, the PF ratio less than 150. They found that the 28-day mortality was almost half the control group, that is 16%, 32.8 in the control group. Unadjusted 90-day mortality was around 23.6 and 41%. Another thing which was missed in the previous studies was that the duration of proning. They tried it for very short durations, and they came out with the result that it was not helpful. But this study, they saw that at least 12 hours, preferably up to 16 hours, was continued, and they found that there was a mortality benefit. So what is the practice? So you have a patient who has refractory hypoxemia, you tried your ventilatory strategies, you put him on early proning is what we usually consider. So any patient with moderate to severe ARDS, consider proning. And now after COVID, you have already started doing even mild ARDS, like awake proning is also being practiced. So ECMO we have already discussed, or there's another detailed talk on that. So what about the fluid strategy? We all know less fluid or negative balance is good for the lungs. So what does the evidence say for ARDS fluid management? So there is already pulmonary edema, we already know that. And if you are liberal in giving fluids, so if you don't consider deresuscitation, then what is the issue? There will be worsening pulmonary edema. It can be due to increased capillary hydrostatic pressure, decreased oncotic pressure, or increase in the capillary permeability. So what is the evidence for this? There was a study called FACT trial. So it was RCT, which was done in 20 centers. There were two groups. One is conservative group as well as the liberal group. So conservative received less of fluid. So, I mean, the targets were CVP of 4 or the pulmonary pressures were less than 8. And in the liberal group, they received a good amount of fluids with the CVP of 10 to 14 and pulmonary occlusion pressure of 14 to 18. So fluid management was monitored over a period of 7 days. And those in the the conservative group, they deresuscitated by giving them some diuretics as well. So primary endpoint was death at 60 days. Secondary endpoints included number of ventilator-free days, ICU-free days, and organ failure days. So what was the result? There was no mortality benefit, but they found that there was improved lung function. So shortened the duration of mechanical ventilation as well as the ICU length of stay. And there was no increase in the non-pulmonary organ failures. So that is another important point, because we have seen that when we go negative, so when we think that negative is good for the lung and we try conserving or reducing the fluid intake, we see that the kidney takes a toll or hemodynamic instability starts. But here they found that there was no non-pulmonary organ failures were not seen. So the practice recommendation is, so you can go with the conservative management. Initially, if your patient has shock, resuscitate the patient. But once the shock is stable, perfusion is good, consider at least euvolemia, if not negative balance. So, and we have various parameters to assess what should be the fluid status. You are using a bedside ultrasound, or if you have a hemodynamic monitor, you can monitor the extravascular lung water as well as the permeability index as well. So this is about the fluid management. Next, coming to the neurovascular blockers. So there was evidence. I'll go to the evidence. So it recommended that there was a mortality benefit when neuromuscular blockers were used. But what is the physiology, or what was the rationale? Why did the study about neuromuscular blockers? Mainly decreases the patient ventilator dysynchrony, because we already know there is acute lung injury or inflammation is happening in the lungs in ARDS, and we don't want to worsen. That's what we are mainly thinking when we are ventilating a patient or managing a patient with ARDS. So we don't want to worsen the ventilator-induced lung injury or ongoing injury. So that is when the role of neuromuscular blocker comes. If your patient is in moderate to severe forms of ARDS, you are ventilating this patient, you don't want him to fight on the ventilator. There should not be any dysynchrony. The only way is deep sedation, definitely yes. If that doesn't work, then you'll have to go ahead with the neuromuscular blocker. Decrease oxygen consumption, because it reduces the work of breathing. Your respiratory accessory muscles being used for oxygenation are paralyzed, so they take some rest. So the oxygen becomes better. The oxygen, whichever is available, will go to the vital organs instead of being wasted in the respiratory muscles. And better lung compliance, is it? So what is the evidence? So Acrasis, this was the famous study which was there. So it was done in 20 European ICUs, 340 patients, double-blinded. Mainly they gave cisatracurium infusion. It was given a bolus of 15 mg followed by 37.5 mg per hour infusion up to 48 hours. So they followed lung protective ventilation with low P. The other control group had deep sedation in this group. There were some incidences of pneumothorax. What was the final outcome? Is early administration of neuromuscular blockers, when adjusted to 90-day survival, said that there was some ventilator-free days without increasing any muscle weakness. That was the worry. So when you said there was use of neuromuscular blockers, the worry comes is, what about my patient having weakness post discharge from the ICU? So they found that there was no significant muscle weakness. Next, to check whether this, because there were some deficits in the previous trial, they did something called as ROSE trial. This was a bigger study, 48 ICUs in the US, 1,006 patients, unblinded, same drug was used. Only thing was control group, they kept them under light sedation, whereas in the previous study, it was deep sedation. So lung protective ventilation with high PEEP were used. So what was the finding? They found that there was no significant difference. They said that there is no mandatory use for neuromuscular, there is no mortality benefit. So do you ask, what do I do bedside? If your patient is fighting on the ventilator, then you'll have to paralyze your patient. You'll require a neuromuscular blocker agent. Once your PF ratios are better, when the patient is, oxygenation is better, so then you can come down on your neuromuscular blocker, keep him under sedation, and slowly can wean him off from sedation. Try to reduce your neuromuscular blocker as early as possible. So this is what we usually practice. So this is the comparison of the two trials. So I told you to tailor it to the patient's need. Don't try to think about neuromuscular blockers in mild forms of ARDS and all. Think about it in severe forms of ARDS where there is a lot of dysynchrony and all. So how to monitor? So there was a discussion between how to monitor neuromuscular blockers. Maybe we may have a neuromuscular monitoring which may be required bedside, along with the amount of sedation, like BIS monitoring for the sedation, as well as TOF monitoring for the neuromuscular blocker. Titrate it to the effect, because each patient responds to it differently. So we may have further studies on this as well. Now coming to the role of steroids. So if you had seen before COVID, there was no for steroids in ARDS. All this hype started again because of COVID. So what was the recommendation? So, I mean, what is the rationale before starting steroids? This is because of inflammation. So we all know we had classified ARDS into exudative phase, proliferative phase, and the fibrotic phase. And we all know initially there is high inflammatory storm. So the main logic when they started using steroids was first was prevention of ARDS when the when the cytokine storm was high, and later on to prevent the fibrosis which would happen. That is when they started thinking, should we use steroids? That is when we have large number of studies. So you can see many studies. Initial studies had some favoring results, and there was this Meduri et al. Which had some mortality benefit. So, but what is the conclusions? So like sir previously mentioned in the talk, so now because of COVID, we have this separate phenotype of ARDS, like hyperinflammatory and hypoinflammatory. If your patient is a hyperinflammatory, you see that there is a big cytokine storm there, then you consider steroids. If it is not there, then your patient may not benefit from steroids. Actually, it may cause more harm than good. Okay, so titrate it to your patient. If it is hyper inflammatory state, consider steroids. Otherwise, no need to consider steroids. So there are specific conditions in ARDS where you'll consider steroids. Like I told you, if it's hyper inflammatory condition, do give it. Otherwise, if your patient has ARDS because of acute eosinophilic pneumonia, vasculitis, cryptogenic organizing pneumonia, acute hypersensitivity pneumonitis, interstitial pneumonitis due to other connective tissue disorders, or you have patient has ARDS plus septic shock and you're using your steroids for improvement of the shock, you can continue using it, or in COPD. So these are the specific recommendations where you use it. Otherwise, other ARDS, no role for steroids. Now coming to vasodilators in ARDS, again, what's the rationale in using? So I told you what is a big problem in ARDS. It is the VQ mismatch or the shunting which is happening. So that part of the lung is collapsed or atelectatic. There is perfusion happening, but no oxygenation exchange happening. So that is leading to large amount of shunt, and that is significantly contributing to hypoxemia. So because of this, what they thought, maybe if I dilate that particular vessel, which is being ventilated. So if I increase the transfer of oxygen, that may improve the oxygenation. So that was the logic. So you can see it on this slide here. Sorry. So you can see it here. So this is that part of the lung which is atelectatic and there is no gas exchange happening, but you can see that the blood flow is still happening. So this is shunting. So there is right to left shunt, no gas exchange happening. So what they did is they gave inhaled nitric oxide or inhaled prostaglandins. So this only went to those alveoli which had some access to, which were inflated, which were taking part in gas exchange. So this caused vasodilatation only in that particular areas. So when the vasodilatation happened only in those areas which were well ventilated, it led to better gas exchange, VQ became better, oxygenation became better. So this was the logic when they tried using it. Similar thing here also, so you can see here. So there was VQ mismatch. See, this particular valvula is not getting ventilated, but it is equally getting perfused. So this led to decrease in the saturation. But again, they checked even IV vasodilators were given, pulmonary vasodilators. So when you give IV vasodilator, what is the problem is it causes vasodilatation of all the vessels, irrespective of whether it is being ventilated or not ventilated. So again, it did not make a big difference. Again, it led to large amount of shunting. Whereas if you use an inhalation vasodilator, it will only go vasodilate that particular alveoli which can take part in gas exchange. So you can see ventilation is good. There is pulmonary vasodilatation, VQ matching, and better oxygenation. So what is the evidence? So there was a big study which happened. I don't think you'll see any more studies because it was a clear no. There was no benefit at all. So maybe as a rescue therapy, say you tried everything. So your patient, there is still persistent hypoxemia. You can try it, but otherwise no recommendation at all. Now to the role of beta agonists. Again, what is the rationale of recommending or trying a beta agonist in ARDS? We all know beta agonists are good in clearing pulmonary edema. Correct. We have been using nebulizations of beta agonists for clearing pulmonary edema. So this was the rationale why they tried it in ARDS, because we know ARDS has pulmonary edema. So again, there were two studies, ALTA study, 282 patients, aerosolized albuterol versus aerosolized saline, ventilator-free days, no difference at all. And hospital deaths, actually it was higher in the albuterol group, so no for inhalational beta agonists. Another one is BALTI-2 study, 326 patients, PF ratio less than 200, IV salbutamol versus placebo. No difference. Actually, the mortality was high. So any role for beta agonists, no role for beta agonists. Next is statins. So again, why did they consider statins? So apart from it being HMG-CoA reductase inhibitors, good in reducing the cholesterol, it has some anti-inflammatory or immunomodulatory actions. So that is why they considered statins in ARDS, so that it can change the immunomodulatory, make some immunomodulatory changes and reduce the effects. There were two big studies, simvastatin and rosuvastatin were used in the studies, but ultimately final thing is no benefit, no mortality benefit, no ventilator-free days. There were no changes at all. So there's no recommendation for any role of statin in ARDS management. Nutrition. So like everything, every patient in ICU requires nutrition. Here also similar recommendations. I'll tell you what was specific with respect to ARDS. So initially the assumption was that high carbohydrate diet leads to high carbon dioxide production, and this high carbon dioxide leads to increased workload on the lungs, but that is a myth. So there's nothing like that. So if you want to give high calories, you can try high fat diet and you can cut down on the carbohydrates. You can't make it zero anyways. So enteral nutrition, we all know, is very, very highly recommended, because your patient, if you rest the gut, again it will lead to bacterial translocation, multi-organ dysfunction and all. So major trial, there was a trial which compared omega-3 fatty acids versus omega-6 fatty acids to see if it will have any effect. Why was this omega-3 and omega-6 compared is that omega-3 were, fatty acids were known to, they are less inflammatory compared to omega-6. Omega-6 led to production of large amount of inflammatory mediators like our lipoxygenase pathway. We know those leukotrienes and chemokines and all, but that was less in omega-3. That's why they compared omega-3 versus omega-6. Again, no big difference. Again, delayed nutrition, early nutrition, no big difference. And ultimately, I mean, whatever is your regular practice in the ICU, give nutrition. If there's any contraindication, start some form of nutrition, either enteral, partial parenteral, or completely total parenteral. But there is no major effect on the ARDS management. So this slide is very familiar. This is my last slide. So I'll sum up both the ventilator and the non-ventilatory strategies. What is the evidence? What is the recommendation? So I'll tell you how to read this picture. The recommendation, the ones with green are, you should do this recommendation. There is a strong recommendation and you should follow it. So what are those? Low tidal volume ventilation, prone positioning, and conservative fluid management. So in your patient, this has strong recommendation. You should follow it. So next, coming to the orange, this has some evidence. Still, we don't have good, strong RCTs which will recommend it. So you can consider when you're doing it, maybe in the future, you'll have some studies which will favor this. So keeping the drying pressure less than 15 and the mechanical power. Next, other agents which are in gray are, you can consider in special cases. That's what I told you. Say, as a salvage therapy, you can still consider, which includes inhaled pulmonary vasodilators or neuromuscular blockade. These three, based on specific patient requirements, you can consider. So glucocorticoids, individualized PEEP titration, and VV ECMO. So this is about the ventilatory management.